demonstrated in the viscera is very little. Theory will be asked. Like suppose we take for example the stomach. First you have to decide out of the two ends which one is cardiac end, which one is pyloric end. Thicker end will be pyloric end, thinner end will be cardiac end. Then you can easily see which one is lesser curvature, which one is greater curvature. Okay. So what you need to do, obviously keep the cardiac end above, pyloric end below, and the lesser curvature should be facing towards your own right side, because lesser curvature gives attached to lesser momentum. At one end it is attached to stomach, at the other end to liver. Liver is the right side, so this lesser curvature should face towards your right side. This is the actual anatomic position, not like this. This is wrong because here the lesser curvature facing towards your own left. So this is the position. Then the first thing that can be asked here is what are the parts? See, there are two orifices, cardiac, pyloric. There are two curvatures, lesser curvature, greater curvature. There are two surfaces, anterior superior, posterior inferior. You can also tell anterior posterior, that won't be wrong. Then what are the three parts? Fundus. This is the cardiac part. Above that, fundus, then body, then pyloric part. And pyloric part has got further three parts: pyloric antrum, pyloric canal, pyloric orifice. This is all that needs to be demonstrated. Then comes the theory. So what are the common spotting questions? First thing, when they put the stomach, they can ask what is the capacity. For the viscera, always remember the dimension. And for stomach, it is capacity 1 to 1.5 liters in adults. Then next question can be what are the parts? Very easy. Fundus, body, pylorus, and if you have got time, write that the pyloric part has got three subparts. Okay, pyloric antrum, pyloric canal, pyloric orifice. Then the next question can be spotting question. Name 2 to 4 arteries of the stomach. That is along lesser curvature, left and right gastric artery, along greater curvature, left and right gastrocolic artery. Or they can write what are the arteries along lesser curvature, or what are the arteries along greater curvature. The next question is name some viscera in the stomach bed. Okay, so read the stomach bed. What is there? You all know that is body of pancreas, tortuosplenic artery, that is kidney with the suprarenal gland, that is spleen, that is transverse mesocolon, not transverse colon, transverse mesocolon. So remember 4 to 5 which can be asked in the spotting. Then when you face it in your window or your grand viva, again parts can be asked, capacity, everything, but what we will concentrate on mainly is the artery supply, venous drainage, lymphatic drainage. Most of them can be asked, but artery supply, venous drainage, lymphatic drainage are more commonly asked, and so is asked stomach bed. Okay, so read that clearly. So this is all, and when you read any viscera, always prepare its 4 or 5 functions. They can be asked in the function of stomach. So partial digestion of proteins, it serves as a temporary storage of food, it secretes hydrochloric acid, it secretes your intrinsic factor. You know what is the function. Okay, read 4 times. Read the source of development and anomaly. These two things you prepare when you are preparing for the viva, or that is the window or the grand viva. Okay. For stomach, development is simply 4-1, and in the anomaly they can ask about congenital hypertrophic pyloric stenosis. Okay, like that. So read the anomalies and read the source of development. So as you have seen, what you need to do with the stomach, put it under the position, tell the parts. Rest is theory. There is nothing much to demonstrate here. Okay. Then coming to the spleen. Spleen, there is a bit of a demonstration, but see one thing. In spleen, you always know the upper border should have the notches. So see here, if you see this spleen, you can find that the notches are on this border as well as on this border. Now, which one is the upper border is the question. The thing is, apart from the fact that the upper border is notched, there is another fact for holding the spleen in position, that is the upper impression which contains the hilum should be larger compared to the lower impression. So if you tell this is the upper impression of hilum, this should be larger. Okay, so this is the anatomical position of the spleen. Okay, so have the two things in mind. Then what they ask, parts. So this is posterior end or medial end. So this is posterior end or medial end. Then this is the anterior end or lateral end. Then the borders are very easy to demonstrate. Upper border or superior border, intermediate border, inferior border. Then the surfaces. See, you should always hold the spleen on your left palm, like this. Okay, making it not like this, just like this, like you hold a picture. Okay. And here there are two surfaces. This is the visceral surface, and the surface resting on my palm is the diaphragmatic surface. What you get on diaphragm surface? Obviously diaphragm and 3 ribs. What are the left 9, 10, 11, out of which 10th is the axis. Left 10, 3 is the axis of spleen. That is very commonly asked, which is the axis of the spleen. Then you have to identify these impressions. So this is upper gastric impression, which contains the hilum. This is renal impression. Then just in front of the hilum is very small area that is known as pancreatic impression. Then colic impression. What they can do when they put this spleen just like this in spotting, the first thing they can ask, that is not very common, but they can ask about the function. Two functions you never forget in your whole life. In fetal life, it is blood forming. In adult life, it is blood destroying or graveyard of RBC. These two functions you can never forget in your life. Then another thing they ask, if they put this spleen like this, they will probe any of these impressions and ask what impression it is. That is one type of question. Or they can simply ask, write two of the ligaments. Read everything regarding the ligaments of spleen, like gastrosplenic, lienorenal. Not only that, there is phrenicocholic and phrenico-splenic ligament. So see, what are the contents of gastrosplenic and lienorenal ligament are commonly asked. More commonly, lienorenal ligament content. What is the content of gastrosplenic ligament? Short gastric artery and left gastroepiploic artery. What is the content of the lienorenal ligament? Talopancreas and splenic vessels. The lienorenal ligament content is more commonly asked. Okay, and remember one thing, sometimes that's what is pedicle of spleen, that is gastrosplenic ligament and lienorenal ligament taken together. That is called the pedicle of the spleen. Then there is phrenico-splenic ligament that suspends the spleen from phrenic, the diaphragm. That is called suspensory ligament of spleen. Sometimes the gastric ligament is a suspensory ligament of spleen. Or sometimes the lower end of the spleen is supported by the phrenicocholic ligaments. The phrenicocholic, that means the ligament is attached at one end to diaphragm, the other end to colon. But it supports the lower end of spleen, so it is called support of spleen or sustentaculum linis. Sustentaculum means support, lion means spleen. Okay, so that is the sustentaculum linis. Then in the spleen, they ask a bit about the development. Remember, spleen develops in dorsal mesogastrum, and they again ask from which drum layer. See, spleen exclusively develops from the mesoderm. Okay. Then they may ask a bit about the developmental pattern. They ask why there are notches on the spleen. Why there are notches on the spleen? Because the spleen develops in segments and then fuses. So the notches are an indication that it develops in segment and then get fused. Then the next question, sometimes if you answer really well, they ask what is spleniculum or what is accessory spleen. That is in Choracea, it is splenic mass outside its normal position, and what are the locations? All the derivatives of dorsal mesogastrum. Spleen develops in dorsal mesogastrum, so in all the derivatives of dorsal mesogastrum, you will get the spleniculum. So you get from book what are the derivatives of dorsal mesogastrum. That is nothing with gastrosplenic, lienorenal ligament, or deteromentum like that. Apart from that, it can be present in the broad ligament of the uterus or in the left spermatic cord in the male. In the male, it is present in spermatic cord. In the female, it is present in broad ligament. Okay, that means and they ask about splenomegaly and hypersplenism. Splenomegaly means size increased, and hypersplenism means there is increased activity. So these two things, they may coexist, they may not coexist. Okay, and remember the causes. The most common cause of the causes of splenomegaly can be malaria, chronic malaria, malaria of longer duration, or it can be your typhoid, or it can be, if you don't remember, at least you can tell tumor of spleen or metastasis of spleen. In either case, it will be enlarged. Okay, so remember 4 or 5 causes, and chronic myeloid leukemia is another condition where there is splenomegaly. Hypersplenism is also found in malaria and the like. Read the causes. Then another thing, in the spleen they ask about Harris dictum. Sometimes if it is a window question or it is in your viva, they ask what is Harris dictum. Harris dictum regarding spleen is all the odd numbers up to 11 and 10. So 1 inch is the thickness of the spleen, 3 inch it is width, 5 inch it is length, 7 ounces is the weight, ounces OZ is the weight, 9 to 11 ribs are related to it, and remember 10 because left 10th rib is the axis. Sometimes if they hand you over the spleen, they ask about the functions first or what is Harris dictum. Okay, and remember about red pulp and white pulp. That can be also asked in the viva. What is red pulp? 2 things, sinusoids and the boundaries. What are the boundaries? Spots of Billroth. What is white pearl? There is centrally placed arteriole surrounded by a lymphatic set. At least you know this much, and if you answered well, they ask which one is more out of red pearl or white pearl. 75% is red pearl and 25% is white pearl. Sometimes they ask, does the spleen move with respiration? Yes. All the subdiaphragmatic organs move with respiration along with the movement of the diaphragm. That can be kidney, that can be spleen. Okay, so remember that, and they ask whether spleen is essential to life or not. No. If you remove the spleen, there will be increased chances of infection, but the person can survive with due precautions. Okay, so these are the common things asked regarding spleen. So this is all about spleen. The liver, see, a lot of things are to be demonstrated here. If you saw stomach or spleen, very few things are there. But in liver, a lot of things are to be demonstrated. The first thing is how to hold the liver in anatomical position. So see, first thing, this is the IBC. So IBC that I have proved, okay. That should be posterior and that should be vertical. Then the liver should be moved towards the right side with the broad part towards your right and the narrow part towards your left. And the superior surface should be convex, concave, convex from either side. If you go from right to left, convex, concave, convex. If you come from left to right, convex, concave, convex. Okay. Then the next thing is what are the parts? Parts are surfaces, borders. See, what are the surfaces? Very easy. Just hold the liver in position. The part or the surface facing up is superior surface. The surface facing front is anterior surface. The surface facing behind is posterior surface. The surface facing below is inferior surface. And the surface facing towards right and lateral side is right lateral surface. So just hold the liver in position and you can name the surfaces. Then what are the borders? There are three of them: posterior superior, posterior inferior and inferior. Okay. So see, posterior superior border is so called because it intervenes between posterior surface and superior surface. This is superior surface. This is posterior surface. So this border will be posterior superior border. This is posterior surface. This is inferior surface. So intervening between them, this ill-defined border is posterior inferior border, and the surface border is inferior border. That is really well defined. This is the inferior border that separates the inferior surface from the anterior surface and right lateral surface. Okay. Now let us go to the features of individual surfaces. So see, if we see the superior surface, what is above the diaphragm? What is in the diaphragm? Central tendon, two domes. What is above central tendon? Heart with pericardium. What is above each dome? Respective lungs with pleura. Okay. Then what is on the anterior surface? Right side, right costal margin. Left side, left costal margin. In the middle, G4 process. What is the relation of right lateral surface? Just outside, you will first find the diaphragm. Then outside that ribs. Which ribs? 7 to 11. Okay. And we can divide the space between the diaphragm and the ribs into three parts: upper third, middle third, lower third. Upper third has got both lungs and pleura. Then lungs gets finished first. So in the middle third you only get the pleura, but in the lower third that is no lungs, no pleura. Okay. So this is very easy, this surface relation. But in the posterior inferior surface you get many much. Okay. First thing, in the posterior surface, how to tell the features? Start from the right and go to the left. Okay. So this is called the bare area of liver. See, bare area means it is without peritoneum. The bare area means it is the largest non-peritoneal area. That is what is called the bare area. Okay. Now see, what are the boundaries there? See, at the base there is infravena cavity. At the apex there is ligament known as right triangular ligament. That is from the right lobe of the liver to the diaphragm. Above there is superior coronary ligament that is reflected from the liver to diaphragm. Below there is inferior coronary ligament that is reflected from the liver to the right kidney. That is the boundary of the bare area. Then to its left you get the groove for infravena cava, in which infravena cava is present, and then you get the caudate lobe. Then you get a fissure which contains a ligament that is called ligamentum venosum. They invariably ask it is remnant of which structure. Answer is ductus venosus. Okay. Then this small impression is for the esophagus. This is called esophageal impression. So these are the features that you encounter on the posterior surface. Now what is on the inferior surface? For that you start from the left, go to the right. Okay. First you see stomach. See, above was esophagus, so below that here is stomach, area for stomach. Then this fissure is for ligamentum tetracephalis. It is obliterated left umbilical vein. The invariable ask after this ligament they are remnant of what? Okay. Then this is the quadrate lobe. See, quadrate lobe relation wise can be divided in three parts: upper third, middle third, lower third. In the upper third there is momentum. In the middle third there will be the pyloric part of stomach and first part of duodenum. In the lower third there will be transverse colon. Then this is the gallbladder. This green colored sac, the gallbladder that I am holding in the forceps. This is the gallbladder, okay? This green color, it is green discolored because of bile, okay? Now, they can tie the gallbladder and ask its capacity, that is 30 volume, that is 30 to 50 milliliters. What the parts? That is fundus, then body, then neck. They can ask the name of duct of gallbladder, cystic duct. They can ask the name of the artery, cystic artery. They can ask the name of the vein, cystic vein. Cystic artery, they ask the branch of which artery, right hepatic artery, and cystic veins drain through portal vein. That much you have in mind. This is the bare basic that can be asked about the gallbladder. Then to its right, we get one area for the junction between first and second part of duodenum, and this area is for the right colic flexor. So see the symmetry. Initially there was esophagus. Then there is stomach, then there is pyloric part of stomach and first part of duodenum. Then there is junction between first and second part of duodenum. Here is the right transverse colon, and here is the place for the right colic flexor. That's the continuation. Okay, and this is the area for the right kidney and the right suprarenal gland. Apart from that, see this area with all this host of pores, okay, can be probed. This is the porta hepatis. Okay, this is a very commonly pore spotting. They can probe the porta hepatis and ask what passes through it at the side question. Duct artery vein, before backwards, duct artery vein, before backwards means anterior to posterior. Duct are right and left hepatic duct, not bile. Then there is right and left branch of hepatic artery and right and left division of portal vein. That is what passes through the porta hepatis. And this enlargement is the tuberomental. Tuberomental of liver faces towards tuberomental of pancreas. Okay, that is why they are correspondingly named. Now, this is what you need to demonstrate. Then they can ask about the ligaments of liver. They can be true ligaments, false ligament. True ligaments are embryonic folds, ligamentum teres hepatis, ligamentum venosum. False ligaments are lesser omentum. The right triangular ligament that extends from right lobe to the diaphragm. Left triangular, see this is the left triangular that extends from left lobe of liver to the diaphragm. Then there is coronary ligament, superior layer, inferior layer, superior layer reflected from the area of liver to the diaphragm, inferior layer from the liver to the kidney. Okay, and that is falciform ligament. That is this ligament. See, this membrane-like structure attracts to the upper and anterior surface of liver. This one is your falciform ligament, the falciform ligament. At one end attracts to superior surface and anterior surface of liver, at the other end to anterior abdominal wall and the diaphragm. Okay. Then sometimes they ask what are the contents of falciform ligament, that is ligamentum teres. Then there is portal system saccade. Okay, and that is some diaphragmatic veins. Okay, read that from the book. Then they can ask the lobes of the liver. The next high-back question, lobes of the liver. So there is anatomical division of the lobes, physiological division. The anatomical division is by the, if you make a line by joining falciform ligament, ligamentum venosum, ligamentum teres, that line divides the liver into anatomical right lobe, anatomical left lobe. Then the physiological division is by the cholecystophenous line. We join the groove for infravena cava with the fossa for gallbladder. That is called cholecystophenous line that divides the liver into physiological right and left lobe. Then apart from that, there is quadrate lobe, that is quadrate lobe, that is the radial lobe. That is an extension from the inferior border of the liver, and that is an occasional lobe. Tongue-like projection and occasional lobe, not always found. Okay. So then a very common question is nutrition of liver, source of nutrition, measured by the portal vein, a bit by the hepatic artery. Then they can ask about the histology, but some ask, some don't ask. And they can ask one thing about the hepatic arterial segments. Okay, so there what happens, remember, there is a right lobe and left lobe. The left lobe has got two divisions, medial lateral. Right lobe has got anterior posterior. Then each of the four gets divided into upper part and lower part. So altogether 8 segments. So remember the remaining LML. Okay, left lobe, medial lateral. Then PR, right, posterior anterior. Then each of them, posterior anterior, lateral, medial, gets divided into upper lobe. So altogether 8 segments. Okay. So that is all that needs to be demonstrated in the liver. Then the kidney is again minimum demonstration, maximum theory. So see, first thing is, when they ask about the kidney in the spotting, you should always be able to correctly tell the side. If you make the side wrong, everything becomes 0. They won't award you any mark. Okay. First thing, one thing, the hilum of the kidney should always be medial. Second thing, at the hilum, the structure going down should be ureter, and that should be most posterior. See, here you can find this bunch is the vein and artery taken together, and behind you can find the ureter that should go down, or else it's difficult to tell. Okay, and here if I make it the right kidney, see, the ureter is the posterior structure at the hilum. Here the vessels are in front and the ureter is behind. I am telling this right kidney. Suppose I make this left kidney. I force it on left side. So what is happening? The hilum is medial again, but at the hilum, see, the ureter, it is becoming anterior. So this is the wrong side. This is the right side kidney I am holding. What are the parts? Upper end or upper pole, lower end or lower pole, lateral border, medial border with the hilum. When they put the kidney in spotting, a very common question is what passes through the hilum. From before backwards, anterior posterior, VAU. Renal vein, renal artery, ureter, you can write the pelvis of ureter. Same thing, because the part of ureter up to lower pole is called pelvis. Okay, so you can write vein artery ureter or vein artery pelvis of ureter. Same thing. Okay. Then what are the surfaces? Anterior surface, posterior surface. They will ask name 2 to 4 structures in the anterior surface or posterior surface as the side question. So what are the structures in the anterior surface of right kidney? This is for the suprarenal area. This area is for duodenum. Then for liver. Then see below, the inner area is for jejunum, outer area is for colon. Jejunal area, colic area. Then what is the posterior relation of the right kidney? Above that is diaphragm with only one rib, 12th rib, because the liver is there, it displaces the kidney a bit below. Then 3 things you know that. Medial lateral, PQT, was measured there, then quadratus lumborum, then T for transverse abdominis. On the quadratus lumborum, there is your 3 things: subcostal basilar nerve, iliohypogastric nerve, ilioinguinal nerve, and in addition to that, on the right side, that is right fourth lumbar artery. That is fourth lumbar artery. That is relation. So they may ask write 2 to 4 structures on the anterior surface or write 2 to 4 structures on the posterior surface as the side question in the spotting. Now let us the left kidney. See again here, same thing. You have to make the hilum medial. But see, if I am making this the left kidney, see this bunch in front that I am holding it the forceps is the vessels, vein and artery. Okay, and this is the ureter, and that is going down, and the posterior most. If I force it on the right side, see again the hilum is medial, but the ureter that is going down becomes anterior structure. So this is not to be done. This is the left side kidney. Parts are the same: upper pole, lower pole, lateral border, medial border of the hilum, anterior surface, posterior surface. But again, the relations are different. On the anterior surface, you get this is the suprarenal area, this is the splenic area, in between the two, gastric area, then pancreatic area, then below same, inner side, jejunal area, outer side, colic area. Always on any kidney, inside, jejunal area, outside, colic area. Then what is there on the posterior surface? Upper part, lower part. Again, the upper part you get diaphragm, but 2 ribs, 11th rib, 12th rib. Because of the absence of liver here, the left kidney is a bit above. Okay. Then apart from that, the lower part. So again, same thing. 3 muscles from medial lateral PQT. On the quadratus lumborum, you get subcostal basilar nerve. Below that, iliohypogastric nerve. Below that, ilioinguinal nerve. And there is no fourth lumbar artery here. There is no fourth lumbar artery here. Remember the functions of kidney. Formation of urine, excretion of nitrogenous waste substance, formation of erythropoietin, renin. You should know the function of erythropoietin. Okay, that much is enough. Then here there is another arterial segment. Arterial segment is of kidney. That can be asked in the fiber if you answer well. So see, there are 2 divisions: anterior division, posterior division of renal artery. They are called segmental artery. So anterior segmental artery, posterior segmental artery. Posterior segment is single, but in the anterior segment you get 4 divisions. AMUL, A, M, U, L. Upper, apical, upper middle. I mean A for apical, M for middle, U for upper, L for lower. Okay, that is the anterior surface. Anterior segment, posterior segment is single. There is no division there. So have the idea about renal arterial segment and hepatic arterial segment. That can be asked. Obviously to answer well. If you don't answer initial things well, they won't ask that. Then kidney, remember the development. Sometimes they just put the kidney at the spotting and ask create the source of development. That is not covered yet. But when you prepare kidney for your fast crop, read the development and the developmental anomalies. Development means both source of development as well as anomaly. Okay, so at least remember from this class that there are 2 parts in the kidney, in the uniferous tubule. One is called secreting part, one is called collecting part. The secreting part develops from metanephric blastema, the collecting part develops from ureteric bud. You can remember that if you try. So at least remember this much, the name of the sources of the development of the kidney. Okay. Then if there is a section of kidney, they can ask about the interior, but that is again not a very common question. Okay, not a very common question. So at least you can identify the pyramids here. Okay. See, as I told you, apart from the demonstration, you have to read the theory. They can ask that. Okay. So let's talk about the.
सर वो राइट किडनी का रिलेशन बता दीजिएगा.
Anterior surface or posterior?
एंटीरियर सर.
This is supranal area. This is duodenal area. This is hepatic area. Inside duodenal area, outside colic area. See, take this kidney. You get this kidney, then you find one thing, hilum, that's the medial, and at the hilum, the structure going down is ureter. The ureter should be the posterior structure. So in front of it, this is the renal vein. See that three things here. This is the renal vein, very thin one. Then renal artery, and this is the ureter. That's the posterior. So if I make it the right kidney, here the kidney is going down and becoming posterior. But suppose I force it on the left side. See that in this case, hilum is medial. Ureter going down, but it is becoming anterior structure. This is wrong side. Similarly, if you see this kidney over here, this bunch is the vessel in front. This is the ureter going down. See, if I hold it to the left side, the ureter going down is the posterior structure of the hilum. But if I force it on the left side, so for the right side, what you get? This is your anterior structure. So this should not be done. This is the left kidney, and this is the right kidney. Okay. Lower limb, then lower. Lower limb, you have already given one PCT, so must be clear. So, in the gluteal lesion, all that is usually sticking is the gluteus medius. Okay. Sorry, the maximus, not medius. Here there are many muscles of the gluteal group. Gluteus maximus, and you all know what is asked regarding this. If you are preparing any muscle for your viva or the spotting, read four things: origin, insertion, nerve supply, action. And usually nerve supply action are asked more commonly because the answer to them is short. That you can do in 1 minute. Okay. What is nerve supply gluteus maximus? What is action?
It's a flexion.
Abduction, extension, and lateral rotation of the hip joint is the function action of the gluteus maximus. Okay. Now, yes, abduction, extension, and lateral rotation. Anything that is at the back of the hip joint can never cause its flexion, because flexion for the hip joint means the thigh moving forwards. So all the muscles that are in front of the hip joint will cause flexion, and all the muscles at the back of the hip joint will cause its extension. Okay. Same for the gluteus maximus, same for the hamstrings. So now, see, this is the thing they can tie. Iliotibial tract. It's a iliotibial tract. Okay. It's the iliotibial tract underneath which I have put one of my fingers. Okay. And they ask, you know, it is modification of fascial atta. They ask two things: attachment in the name ilium tibia, or what are the functions. One function is that it gives attachment to two muscles. What are they? Gluteus and gluteus maximus. 3/4, 5 of gluteus maximus attached to iliotibial tract. Only 1/4 to gluteal tuberosity on the femur. Then another thing, it stabilizes the knee joint during its movement. These are the two functions of the iliotibial tract. Then recognize this muscle, this large muscle very well that I am holding with my right hand, entire right hand. Okay. See, this is the quadriceps femoris, largest muscle in body, and here you get 4 components. Sorry, quadriceps 4. This is rectus femoris, and then there are the 3 fasces. See, in the disarticulated lower limb, sometimes in the nervousness in the exam, you tend to confuse between medial side and lateral side. So first thing, in lower limb, medial side is great toe, lateral side is little toe, or the head of femur is towards the medial side. But sometimes the head of the femur may not be there, so rely on this because it is very fundamental, almost common sense, but you tend to mistake this in the exam. Which one is medial side, which one is lateral side. Okay. Then see over here, this is the rectus femoris, and these 3 are the vastus muscles. So towards lateral side, this will be vastus lateralis. Then towards medial side, this will be vastus medialis, and in the middle there will be vastus intermedius. Any of the 4 can be tied, and see that there is very little to remember for the insertion or action. All the muscles are inserted into patella. Patella is a sesamoid bone in the tendon of quadriceps femoris, and all of them have got a lone action, that is extension of the knee joint. That is the extension of the knee joint. Any muscle you take in the quadriceps. Okay. Then see, this is already tied. You see, this you sartorius. Okay. No PCT in lower limb is completed without trying this. At least you should get sartorius advanced spotting in the lower limb PCT. Now, remember 4 things: origination of action. Remember its length 18 inches, and sometimes if they are asking about sartorius in the Viva, they ask the length 18 inches, then they ask name the other 18 structures in the body. That is femur, then ductus deferens, then spinal cord. Okay. Huh? Thoracic duct, not azagus vein, thoracic duct. Okay. So read everything about sartorius. Then see when you get the thigh, first isolate 3 muscles. Is this sartorius, gracilis, limited muscles. So see over here, see this bunch. See this bunch over here, beneath which I have put the forceps. You get 3 things. This is sartorius, that is tied. Okay. See, this is sartorius, that is tied. The tie structure is sartorius, that is in front. This is sartorius. Then behind that you get this muscle is gracilis, and this is your semitendinosus. Okay. So always identify these 3 muscles first. If you get thigh. Okay. Then there is the femoral triangle. You all know the boundaries. Laterally there is your sartorius, medially adductor longus. Then they ask about the content, femoral vein, artery, nerve. So the medial most structure will be vein. So over here you see this is the vein. See this, here you can find that this is one vein, this is artery, and this thing over here is the nerve. Okay. So see over here, this is the vein, medial most structure, then the artery, femoral artery, and then this is the nerve. If you are having any difficulty in differentiating between vein and artery, palpate. Thin walled vein, thick walled artery. There is a lot of confusion here in the femoral vessel as well as the popliteal vessel. So if you are confused, palpate. Okay. Then you know the floor. That is first will be adductor longus, then PPI, pectineus, psoas major, and iliacus. Okay. Then if front, see the window question can be either front of the thigh or femoral triangle. If the front of thigh is a question, they may ask about adductor canal. So read theory about that. What are the boundary, what are the contents. So that is the front of the thigh. In the medial side of thigh, you get 3 muscles. Only what are the adductor, longus, brevis, magnus. So see over here, this structure is the longus. This is the brevis, shorter one. So this is the longus muscle, that is longer. Then deep to that you get the brevis, this one shorter, and the larger muscle, this is the magnus. Longus is longer, brevis is this one is brevis, that is shorter, and the larger one is magnus. And see, this is adductor longus, longer one, this is brevis, shorter one, and this is magnus, larger one. Okay. See longus, longer, brevis, shorter, magnus, larger. And here read about the operator nerve. What are the root value, what are the divisions, what are the branches. That can be asked. See, anything here can be the window question, front of thigh, femoral triangle, or the medial compartment. Then there is only one compartment remaining, that is the posterior compartment, or which has got the hamstring muscle. Name the hamstrings. Semimembranosus, semitendinosus,
long head of bicep femoris.
Don't tell bicep femoris. The proper answer is long head of bicep femoris and ischial head of adductor magnus. See how to identify them. Only one muscle, biceps femoris, is on the lateral side. Rest 3 are on the medial side. See on the lateral side, as you can see this muscle. This one is the biceps. This is the long head, and this is the short one. Okay. Then on the medial side, what you get? See this muscle over here. This one is semitendinosus, half of the muscle is like a tendon. Then this is semimembranosus, half of the muscle is like thin like membrane, and this is adductor magnus. And this nerve, never forget, it is sciatic. This is sciatic nerve. What is the root value of sciatic nerve? L4, 5, base 1, 2, 3. And what are the 2 divisions? That is
tibial nerve and common peroneal.
And remember the 4 properties of the hamstrings, origination of the action. And sometimes here in the window they may ask what are true hamstrings and what are false hamstrings. True hamstrings are symmetrical. False hamstrings are the other 2. Okay, why?
Because they are present in other compartments.
But the proper answer is, you know the 4 criteria. You know the 4 criteria of the hamstring. Semitendinosus satisfy all the criteria. But if you see biceps femoris, it actually arises from ilium and sacrum. but then the origin gets shifted to ischial tuberosity, so that the sacrotuberous ligament it is degenerated origin. Similarly, adductor magnus it initially gets inserted into the tibia. Later, the insertion migrates to femur. Okay, that is where it is also a modified hamstring. Now that is all about hamstring. You know the popliteal fossa. This is difficult to demonstrate curvature. You know the boundaries. Okay, superomedially there will be these two things: semi-tendinosus, semi-membranosus, superlateral biceps. Then inferiorly, inferomedially medial gastrocnemius, equilateral lateral gastrocnemius, and plantaris. Let us see whether that muscle is here. यहाँ plantaris दिख नहीं रहा, ठीक है. Then the contents you know, deepest one is artery. See, there is a lot of mnemonic, lateral to medial, medial lateral, NAV, VN, but remember for practical, deepest structure is the artery, that is the popliteal artery, then the popliteal vein, then the two nerves, tibial nerve and common peroneal nerve, and any of the components can be tied. They may tie the artery vein or the two nerves, tibial common peroneal. So remember the root value of tibial common peroneal as well, and another side question can be what the supply. So remember 2 to 3 muscles supplied by each of the nerve, tibial and common peroneal.
tibial common peroneal टाई करे तो नीचे से ट्राई करेगा ना.
ये ट्राई करना मुश्किल है. मतलब देखो यहाँ पे तो पता चल रहा है कि ये तुम्हारा टिबियल और ये वाला कॉमन पेरोनियल है, लेकिन नीचे कहाँ पे दिख रहा है कि हाँ अगर यहाँ पे इसे काटा हुआ है तो टिबियल दिखेगा, फिर कॉमन पेरोनियल आगे जाकर सुपर डीप पेरोनियल हो जाएगा. तो यहाँ नहीं ट्राई करेंगे, ट्राई करेंगे तो यही करेंगे, ठीक है. देन so let me finish once, then I will show the back students again only the demonstration. So what, then the back of the leg can be a full window. What are the muscles there? See, so see over here, this is gastrocnemius and this one is soleus. This is tendoachilles. Tendoachilles can be tied, and see, then you have to rely on the relation for the rest of the structures. That is, you have to go to the medial malleolus and come there from medial lateral. So what is mnemonic for the posterior? So T, past doctors, T for tibialis posterior. So just behind medial malleolus you get tibialis posterior. Then you get doctors. This is flexor digitorum. Then you get the artery and nerve. So that is really difficult here. See, this is the tibial nerve. See, this nerve is the tibial nerve, and the artery is somehow cut here. And see, then this thing that you see really deeper, this is the flexor, hallucis longus. Okay. So if you identify the muscles here, so this is the tibialis posterior, this is flexor digitorum. Okay, and this tendon really deep is flexor hallucis longus. And see, this nerve here is tibial nerve, and the vessels are torn here, cut here. Okay. Then you see the anterior compartment. See this thing that is tied over here. Mark what is tied over here. This is the flexor retinaculum. This is the flexor retinaculum that is tied here. They may ask the attachment that is from calcaneus to medial malleolus and the structures passing beneath it that you know. The doctors are the pointers. Okay. This is the structure tied is the flexor retinaculum. Okay. Then last two things in the front, what you get? The Himalaya southern dry places. Again, start from medial side, go to lateral. This is not very clear here because many things are cut, and this is better over here. So see, immediately in front of this medial malleolus, you get, see, this muscle is, let me see, yes, this is your tibialis anterior. Then extensor hallucis. So this is going towards the great toe hallucis. Then this is your extensor digitorum having multiple slips, and this last muscle is peroneus torsius. Okay, and apart from that, if you strain a bit, you can see the artery and vein here that you can find on your own. Then lateral compartment, only two muscles, but that is a full window question. So always go to lateral malleolus. Get the two muscles, longus and brevis. See, always the superficial muscle is peroneus longus, and the deep muscle is peroneus brevis. Sole is not asked as a window here, and all this tie in the sole. Plantar aponeurosis. Okay. That is all. See, if somebody has not seen the lower limb, they can come forward or they can go and revise.
So the compartments are. तो आपका
3 कंपार्टमेंट जो है थाई के, 3 कंपार्टमेंट लेग के, उसमें से कोई भी विंडो है, कोई भी फाइबर है, ग्रैंड फाइबर है, ठीक है. शायद ग्रैंड फाइबर में शॉर्ट पार्ट ना डाले वो नहीं कुछ है, विंडो में इधर डाल देते हैं.